Good afternoon. My name is Drees, and I'm blessed to serve as Chief Philanthropy Officer for Providence St. Jude Memorial Foundation. I'd like to welcome you all to today's special program. Our Meet the Experts webcast is being hosted exclusively for St. Jude's closest donors and friends to give an insider's view of the latest advancements and achievements within our nationally recognized and award-winning cardiac care program. I'd like to begin by introducing our cardiac care panelists. First, Dr. Eugene Byun. Dr. Byun is a board-certified cardiologist specializing in structural heart procedures such as transcatheter aortic valve replacement, also known as TAVR, and he also serves as co-medical director of our cardiac Cath lab. Next, Dr. Michael Chan. Dr. Chan is a board-certified cardiologist specializing in high-risk percutaneous coronary interventions, peripheral vascular disease, and lower extremity and renal artery disease. Our next panelist, Dr. Harry Peled. Dr. Peled is a board-certified cardiologist specializing in interventional cardiology. He also serves as medical director of our cardiovascular services and critical care. And finally, Dr. Taylor Tang. Dr. Tang is a board-certified cardiothoracic surgeon specializing in minimally invasive complex cardiac procedures such as TAVR, complex aorta repair, arch bypass procedures, and surgical ablation of atrial fibrillation. He also serves as medical director of our cardiothoracic surgery. So, without further ado, I'll kick off the questions. Dr. Peled, I'll begin with you. As the veteran of the group, you've been serving at Providence St. Jude for more than 15 years. Can you paint us a picture of what the cardiac program looked like then and now, and some of the key ways in which the community's support has helped us to get to this point?
Sure. When I was recruited here some 15 to 16 years ago, I was actually recruited specifically for the heart program. And that was to do what's called intraoperative transesophageal echocardiography, which is a lot of words and a lot of syllables. But it is to monitor the results of the heart surgery in real time when you're in the operating room, such that if the result is not perfect or what you expected, you can actually fix that right then and there. It's the type of investment that you usually only find in major academic places, but the people back then had a vision of how they wanted to grow the surgery program. And for those who've been around for a while, I remember very distinctly being in a room with Bob Frichetti, Doreen Dan, Lee Penrose, Dr. Alan Borsari, and a lot of others, where what we had then was a good program. It was not a great program. I think a lot of people did a lot of work, to get it where it was. But we've certainly seen tremendous growth in the past few years. And, some of the ways where we've seen that growth and where, really the community support helps is first having the up-to-date cardiac catheterization lab that we have in the Southwest Tower along with the ICUs. When you're doing complex things, you really need the best visualization that one can have. And having an advanced cath lab with the proper space, with the proper equipment, with the proper visualization makes a difference. You can get by with adequate equipment for 90% of the cases, but you never know that 10% where having that extra edge is going to make the difference. So having that cardiac cath lab in the Southwest Tower, which I know a lot of people in the community really contributed to, was one of the steps to get us up to the next level. Another thing was, as part of the Northwest Tower, is the hybrid cath room, which we're using right now very avidly and with a lot of excitement for our TAVR program, as well as our MitraClip program. And what it enables one to do is do essentially what are called hybrid procedures, where you're doing interventional cardiology with the catheter. We don't have to open up things. Combine that with surgeries need be, or if there are complications, that you can really instantly change from a catheter approach to a non-open approach. to a surgical approach. And those things have really grown tremendously over the past 15 years. You know, as I mentioned, when I was first recruited here, it was to do this complex ultrasound in the operating room during surgery. We really had no dreams at that time that we could accomplish with a catheter with a stay of just a couple of days what required surgery. And we'll talk about that a little bit later. But those are really things that we have accomplished over that time. And I think the other thing to mention with that is that technology alone does not improve outcomes. It doesn't improve the service you provide to the community unless you combine it with the proper people and the proper processes. And what having that equipment does is you make sure you get the talented people who want to come down. You know, our surgeons are UCLA trained and USC trained, people who've spent, 5, 8 years of their life, even more training in high level places, want to be able that they can practice to the full extent of their skill sets. You know, same thing with Dr. Chan, he'll talk about later, complex blockages in the arteries. Dr. Byun, who provides a whole range of interventional support. So what that technology does, it's not just technology, but it gets you the people who want to come here, which I think is a tremendous impact. Shortly after I came here, Brian Helen came here. And again, I think when you're talking separately from the physicians, your administrative talent. Brian Helen came about a year after I came. Laura Ramos, people may or may not know, actually used to be the director of the cardiovascular service line in Anaheim, and she's been here since I think about 2008 or so. But again, when you're attracting talent, when people see the community support, when people know they can practice to the full extent of what they've been trained to do, that's how you get people. So on the next slide, there's some sort of objective information as what we've accomplished over the past years. So we are ranked overall as one of the top 2% hospitals nationwide. And what's important about these rankings are based by objective criteria about readmission rate, mortality, quality of care. This is not merely a popularity contest, although of course we do look at the patient experience. If you look at the next slide, is another list of what we've done. And again, when I started here 15 years ago, we did not have walls and walls of this up there, which is, people on campus, they can see what they walk in, and you see, again, a best in overall cardiac care. What's really fun on the next slide is the, 5-star and a whole bunch of things up there. So I will just stop at that point and go on to the next.
Well, thank you. And we are certainly all very proud of all the awards and accolades that our medical center has received. So talk to me a little bit about some of the distinct offerings of our cardiac care program. What type of complex conditions are we able to treat because of each of your highly specialized expertise, or because of technology or facilities that other hospitals may not have?
I could. So I've been here since 2001. So I've been here for 20 years. And, cardiology definitely has changed over the years. Cardiologists used to do angiograms and angioplasties, which at that time, it was not very durable. With technology, with the stents and the drug-coated stents, which is an impregnated stent. Stent's like a metal tube you put inside the artery that keeps it open, almost like a scaffolding. And an angiogram, which I think most people know, is where we put a tube either in the groin or through the wrist to take pictures of the arteries that go to the heart to see where the blockages are. And I guess majority of the time, coronary artery disease is one of the things that we see most of the time as physicians, as cardiologists. Now, the tools we have to treat arteries and the complexity of doing things, just like Dr. Chan does, which I'm sure he'll talk to you more, it has just really blossomed. Not only do we have special equipments, multiple different ways to deliver the equipment to the arteries to keep it open, to get it open. We also have devices that support the heart as we're trying to do these tough cases that we didn't have before. And we also work now closely with the heart surgeons because sometimes it's not always black and white, and to do the arteries and do bypass surgery. So it's a spectrum, all the services that we have. Historically, things that the arteries that cardiologists had treated in the past, now we're expanding into non-surgical ways of treating heart valve conditions, such as the TAVR, which is a transaortic valve replacement. We're not exactly replacing it, but we're putting an artificial heart valve through the vessel in the groin, snaking it up to the heart and putting the actual artificial heart valve inside an old worn out heart valve that used to be surgical. Now we have that option. There's still definitely a role for surgery in this, but if the person's very old, too frail, too sick, and just not a good surgical candidate, then we have that option that we didn't have before. And same thing with the other valve conditions that are deteriorating as we age that we had before. So it's just not the arteries that we're dealing with. And on the side of, I'm sure I think there's people asking about AFib. We have ablations. We don't have an electrophysiologist on this panel that we have the ability. When I started, there was no ablations for AFib. Now we have the ability to make scar tissue either with a catheter that the cardiologist does or the heart surgeon can do from a small hole that they make through the chest wall. So these are electrical system problems, plumbing problems like our arteries, or the valve problems that are all part of the heart that it's just really expanding in terms of what we are able to do now in 2021. And I'm sure this is going to continue to grow. And I think, most medium-sized hospitals like we have, I think we offer that breadth of services that we didn't even have before, even about 5 years ago. So this is happening very fast, and I think it'll continue to occur.
Would either of our other panelists care to talk a little bit about your highly specialized expertise? Dr. Tang or Dr. Chan?
Yeah, sure, I can go. Can you guys hear me okay?
Yes, we can hear you.
Yeah, I think just to kind of, jump on what Dr. Peled and Dr. Byun have been saying, but I think, the thing that's probably best about St. Jude is that we work very well as a team. And, between all of us, I think we can really discuss a patient's case and then consider all the options now that we have so many different things we can do to provide them the best care that's, the best thing for their heart, but also for the whole person. We don't want to just fix the heart and, leave you bedbound or in a nursing facility. We want to treat you as a whole person and give you, the quality of life that we want to preserve and, retain for, a long time. So I think having those options and working with a great team is probably the biggest change I've seen in the field of medicine, that we become much more much more goal oriented and toward a multidisciplinary approach with multiple people looking at the same problem and kind of problem solving that way, instead of just kind of one person doing everything or doing whatever they want to do, but going at it together.
How about you, Dr. Chan?
Sure. So, I'm Dr. Michael Chan. I'm probably the newest member of the team. And Dr. Byun and Dr. Peled have invited me over and asked me to join to help provide services to help with high risk and kind of complex patients. We have an excellent cardiac surgery team program here, but some of those patients are too sick for open heart surgery. And so some of those patients are those that they asked me to help with in terms of fixing blockages and get them through kind of either a heart attack situation or a situation where they may not have any other option besides comfort care. I kind of want to emphasize what Dr. Tang was talking about in terms of the team approach. We really, I think at St. Jude's, what I've noticed is a really strong commitment to a heart team approach and a very collaborative approach to patient care. I think there's excellent specialties across the board, so it allows us to really utilize the best of the best to deliver high quality care for our patients. So it's really been a privilege to work in that environment. So, I take on some of those really high risk patients. We take on things like chronic total occlusions, which is really the last bastion of interventional cardiology in terms of complexity. Those are blockages that are 100% blocked and traditionally really hard to treat. But with newer technologies and skill sets, we've actually had good success in tackling those and be able to deliver options for patients that didn't have options before.
And there's a lot of talk around the MitraClip procedure. Would one of you care to give a little background on that?
Sure. So, as we talked about, some things are better with surgery, some things are better with a percutaneous approach with the catheter. And traditionally, when one has had a leaky valve, the only treatment was surgery. What the MitraClip is basically an overgrown clothespin, and it goes in upside down, and you clip the leaflets together so the blood does not flow backwards. It's sort of basically a plumbing problem. And that's something that we have really just recently added to what we've done over here. We did a couple late last year. One of the challenges with doing this specific procedure, it is one of the most demanding in terms of being able to see precisely inside the heart. You have to be accurate to within 1 or 2 millimeters of what you're doing. And after we did the first couple, we said, we really can't do this in the optimal way until we have the really the best imaging. It's not just a matter of the images. What does that mean to the patient care? So I don't know if you want to talk, Deb, and introduce the next, or if I should.
Sure. No, I'm happy to. So just to sort of tee it up, we're talking about one of the newest breakthrough offerings on the market that St. Jude now offers its patients, the MitraClip. And it just so happens that one of our dearest and most generous donors recently had the opportunity to undergo the MitraClip procedure, making him one of just 3 to receive this life-changing treatment at St. Jude to date. He's given our physicians permission to share about his case today. And I want to thank you, Mr. Malora, who is on the call, for inviting us into your experience. So, Dr. Peled, would you please share about Mr. Malora's case?
Sure. So, Mr. Malora is basically, it was very exciting to meet him. But the bottom line is he has a very leaky valve. And the standard treatment for a leaky valve is open heart surgery with all that involves. And this little picture over him, I apologize in advance if I either bore people or try to get too involved, but I did try to get myself edited too much. This is what his heart looks like before we start. So what you see on the top of the picture is left atrium. That's the receiving chamber. And that red jet that's going up there should not be there. And you can see it's a very big jet. It's very flaming. And that's a severe amount of regurgitation. And that blood should be going forwards, not backwards. And because the blood is going backwards, it makes you short of breath because you're filling up your lungs with fluid. And you get tired because not enough blood is actually moving forward. Now, if you look up near the bottom of the screen at the colored jet, you see those 2 little white things moving up and down. Those are your mitral valve leaflets. So what we're seeing is where he is starting from, is the mitral valve leaflets and that regurgitation jet coming back. What I will mention, which is important for the proper planning, is you really need very precise pictures and very precise imaging. So what we're getting here is what you call a high frame rate. You can really see everything moving. It's not moving in a choppy way. And you can see very clearly the edges of the leaflets and the jet. So that's where we are starting from before we do our intervention. So if you go to the next slide, we're going to give you a fancier picture of this. And this is a 3-dimensional view. And here what's happening is you're looking at the heart from the top and looking down. You're looking at that left atrium, which was on the top. You're actually looking down through the valve. And the ventricle, the main pumping chamber, is below us. And you'll see labeled is the anterior and posterior leaflets, which is a fancy way of saying front and back, and lateral medial, just so you see which the sides are. If you look down the middle, you see they're opening and closing. Now, when they're closing, they're not closing quite the way they should, and that's where your leakage is coming from. Now, again, if you look at the top left of your screen, you'll see where it says 32 hertz. That's the frame rate, which means that we're seeing a very quick, very fast picture. With standard technology, or what we had until just 3 months ago, this would be at 4 hertz. So again, you just didn't really see what you were doing in the way you needed to. So if you go to the next slide, remember we saw that color jet before. So now that's that regurgitation jet. That's the blood going backwards rather than forwards, coming right back at us. So here's where we are starting from. So we get a very good idea before we start how much it's regurgitation, and that it's sort of coming through the middle, so we get an idea as to where to put the clip. And again, what is really stunning, again, for those people who have not seen the other technology, is the amount of detail we have and this very high frame rate, so we're not looking at choppy and we're not guessing at what we're doing. If you go to the next slide, is going to be another perspective of what's happening. So if you look on the left screen, we're looking again, that same picture from above, and now you see that clip, which is about to be deployed in place. It's on a little catheter sticking in. I won't bore you with the details of that, but that's basically the clothespin as it's closed, which is going to go down through the valve. When you look at the right side, you're looking at the valve from the bottom. So again, the ability to see the valve from above and below when you're doing this, again, is fairly incredible. But what that means is you know where you're going and you're not going to get caught into other structures. So again, this better visualization means we can get the job done at the end of the day. If you go to the next slide, I'm going to give you a different perspective of this. And if you look at the right side of your screen, think of that as that clothespin open. And you can see now that that clothespin is partially open. That's sort of Y looking over there. And you see the leaflets moving up and down. So right now you see that the arms of this clothespin are sitting above the valve and the leaflets are moving. When you look at the left side of the screen, you sort of make sure that you're oriented properly and you're not too far to the left, not too far to the right, sort of like porridge, you know, just right and in the middle. And again, this ability to look at multiple pictures, multiple simultaneously, really changes the game and enables us to do this far safer, than would be otherwise. Next slide. So now we have pushed the clip down into the ventricle, into the main pumping chamber. And if you look at that right screen, you can actually see the leaflets inside the gripper. And again, when you look at that left side of the screen, we're just orienting ourselves to make sure we're in the same place. So once we've sort of played and optimized and made sure those leaflets are sitting there, we essentially close the clothespin. And what we do is after we close it, we sort of want to look at it, make sure that we've really made things better. And we can look at that before we actually say, hey, this is the final result and the mission is accomplished. But again, this incredible level of detail, seeing the whole heart at the same time is really a game changer. Next slide. So now what you're seeing on the right side of the screen is what it looks like after the mitral clip is placed. What you'll see in the middle there is that instead of there being one big hole, there are two little holes, and that little red jet compared is much smaller than the big jet on the left. So at 12:23, you had a big red jet coming at you, which was severe mitral regurgitation. Less than an hour and a half later, again, with advanced technology, advanced imaging, and really much a whole team. You know, Dr. Rainey couldn't be here today. He's the operator, as well as Dr. Badarani, who's a CV anesthesiologist. You have dramatically decreased the degree of the leakage. Next slide. And this is just sort of a last finishing slide. Again, with this advanced equipment, this sort of gives you a different perspective. And again, what you see, remember in the beginning, there was one big hole, and now you have two small holes going on. So again, game-changing stuff where it's really totally changed the way things are. And for me, at a personal level, it's really incredible because, as I said, I was recruited here 15 years ago to do complex echocardiography in the operating room. I never had a dream that this would be happen. Now, I'd also want to thank on a highly, highly personal basis, as people probably tell, I'm sort of into the, echo and the imaging. It's part of a team where, I always say it's almost like a general contractor, right? You got plumbers, you got electricians, and, at the end of the day, I'm a mere, compliment to the people who are actually, doing the things. But I do want to thank Paul and Mary Reitler for their incredibly generous donation for this. Their donation is the reason that we can do this today. And it is exciting to me. It's exciting to the community, and it's the sort of thing that makes it exciting. You do this, you train years and years for this. You want to have a better outcome, and to see it in front of your eyes in this way. You asked me in the beginning, what are things like 15 years ago? in many ways, to me, this is like a culmination of 15 years of work of the entire team, of the community, of it really coming together in a way that you've made, people's lives better in their own community without, having to go anywhere else. And we do it at the level as of anybody else.
Truly remarkable. I mean, it's just so fascinating seeing those images. That is the Epic ultrasound system. And I would just like to echo Dr. Peled's thanks to Paul and Mary Reitler for helping to fund the Epic ultrasound system through their establishment of the Paul and Mary Reitler Fund for Cardiac Services. Thank you, Dr. Peled. That was fascinating. And thank you again to Mr. Malora and to the Reitler family for your support. We also want to recognize another family on today's webcast who, like the Reitlers, very recently established a named strategic fund, the Selwood Innovation Fund for Cardiac Care. So thank you, Pierce and Alexis, for this generous gift to our cardiac program. It's obvious that our cardiac care team has a lot to be proud of. And your commitment to excellence continues to earn St. Jude national recognition year after year. We are recognized as one of the nation's highest performing hospitals in cardiac surgery and heart failure by U.S. News and World Report. And we're also one of only 10 hospitals in the state to be designated as a center of excellence in cardiac care treatment by Blue Cross Blue Shield. Of course, there's always the next level of excellence that we are striving for. So talk to me a little bit about how you see our cardiac program evolving. What is your vision for the future, and how can philanthropy help get us there?
I don't know if Dr. Chan, you want to talk about OCT? You're much more.
Sure. So, we're doing complex work in the coronary circulation, and one of the things we've realized through lots of clinical trial data is that when we have better imaging and able to see better what we're working on, we get better results. So there are a number of studies that have shown a 40-50% reduction in problems if we can image as we're doing our procedures. And so we've been trying to bring in better imaging. The imaging we have right now is kind of, we're kind of renting the imaging to get to what we need. I think we'd like to make a full purchase to do that. It's something called OCT, or optical coherence tomography. Consider one of the experts on the West Coast for this, and help train other doctors around the region. But at St. Jude's, we're just kind of bringing it aboard over the last year, and getting additional doctors' kind of expertise on it that we would like to widely implement across the board in the lab. So I think that's something from a infrastructure standpoint we'd like to implement and build the labs out so that we have better imaging qualities to do that.
Yeah, I think from the cardiac surgery standpoint, I think we have a great team. I think the next step forward is to increase our volume and I think provide more of these services to more patients and expand what we can do. And obviously that requires more staff and more instruments and tools and these cool new devices that help patients, but unfortunately are kind of expensive, and to increase how many people we can help with donation.
I can share with you all that we will be this year establishing an endowed chairs program where donors will have the opportunity to establish an endowed chair or a clinical program. And so I think that goes back to what Dr. Peled was saying earlier about attracting world-class talent. And certainly that is, a wonderful recruiting tool when we have those medical endowed chairs in place.
And I think another important part of that is to recruit the people and also to help people have protected time, right? We all know hospitals operate on very small margins. And, to the extent that philanthropy and other funding enables people to focus on programmatic issues, training the staff, working on big pictures, in addition to all the other jobs, being, to the extent that philanthropy helps support and protects people's time, to focus on that is a, really a tremendous thing. In terms, as, Dr. Tang said, as we grow the program, we hope we, do need more of everything right now, because of our, superior quality of this imaging. We're using it for the MitraClip, and we're also using that, sharing that with the OR and working on time. So we're incredibly grateful for what we have, but I think certainly long-term to grow, we certainly could use more of these machines so we can do these in the OR. As a matter of fact, now when we're doing our routine echoes, as MitraClips become more common, we're almost planning for this at the same time, so we can tell patients, you're maybe a candidate, you may not be a candidate, and really get that sort of from beginning to end integrated approach with the heart team. And I think a couple of times people have used, you may have heard us use the term heart team, but that's actually a very specific term. It's making sure that you're doing the right thing for the patient, and whatever decisions are made is not because the surgeon needs to do enough cases, the interventional guy doesn't need to do the right, do enough cases. You're not looking at numbers, that you're looking at quality. And I think that's where really our whole values approach as an institution fits in. And again, and in the more philanthropic support that we have, so we can focus, on the job, obviously, we got to be doing our job to be good stewards, is really tremendous help and support for all of us.
Deb?
Yes.
Do you, I think I can share a case, if you guys got enough time.
Sure. If you would like to go ahead.
Sure. Harry was playing show and tell. I thought I'd do that a little bit here. Let me see if I can do this correctly. Can you see my screen?
Yes.
Okay, good. So, Harry's talking about the mitral valve clip, and I think, that is, going back, the arteries go to the heart, and that's what historically we see a lot of heart attacks, blocked arteries, where we have to fix those, and that's the bread and butter. And the last 8 years or so, the technology of putting an artificial heart valve through the groin has really broadened. And this was a gentleman, I don't think his name is here, so that's good. So this is a gentleman we did. So this is what we do. This is a picture. You can see this is just a regular plain x-ray. Here is his pelvis, his legs. You have the artery that goes to the leg. So we put a tube through here that goes all the way to the heart. And the tube, this is us taking pictures of, here's his aortic valve. Here's his entire heart. So he has a valve that doesn't open very well. It's a very sticky heart valve. And as I tell all my patients, the sticky aortic valve is not a real disease. It's just wear and tear. It's not a condition that's negotiable. It's not something that you can try to fix, exercise your way out of, eat your way out of. It's just a moving part that has a lifespan. Sometimes our valve deteriorates before we do, but sometimes, something happens to us before our valve goes. So this is an aortic valve that's not moving very well. This is the aorta that sends the blood out throughout the rest of the body. So what we do is we're taking some pictures. This is an artificial heart valve that is across the worn out aortic valve. And this looks like a stent, but this is actually a valve structure that is crimped on a catheter. And we just place it just right. And then we expand the valve slowly. Underneath an x-ray. So here's the valve structure being, so that we don't really remove the old valve. We just mash the old valve out of the way. So this ring, this valve structure, the cells, sort of like the chain link fence that's pushing the old valve out of the way. And now the new valve opens up inside this metal mesh. And then that becomes your new heart valve. And it takes about an hour and a half to do this. Like I said, there's some patients who are better served to have this surgically still. But a lot of patients, this is a non-surgical way of doing the TAVR or doing the aortic valve procedure. This gentleman had prior bypass surgery. He was 89 and he was kind of frail. So this will, definitely make him feel better, and it's going to change his prognosis. And so we're doing that a lot these days. And so this is one of the newer programs we've had. And this devices we didn't have 8-10 years ago.
Amazing. Thank you. Thank you so much for sharing that. So we have had a number of questions that have been sent in ahead of time, and we've had a few come in since the program started, but and so I want to be sure to leave enough time for the Q&A. But before we do, for our last question, we'd like to learn a little more about each of you on a personal level. What drew you to St. Jude? What makes St. Jude unique compared to other places you've worked? It's a little something about you that you're comfortable revealing. A talent, a secret talent, a hobby, how many children you have, whatever you care to share. Who would like to go first?
I will go because I still remember being in the room with the leadership some 15, 16 years ago. And I remember they had architectural drawings of buildings to be built in 5 years and 10 years and 15 years. And what I remember at the time is I say, look, I have 5 daughters. I think at that time they were all under 12 or 13. They're relatively close together. And I said, look, if you want somebody who's going to be around to implement your vision and will have to implement your vision and still have to be working, 15, 20 years down the road, I am your person.
Thank you, Dr. Peled. Dr. Chan, how about you?
So good question. I mean, I think St. Jude's is it's well positioned in terms of strengths in a lot of different areas. The patients have been great, and the nursing staff and the staff have been terrific. So I've really enjoyed working with the teams that I've had a chance to work with, as well as my colleagues. Some personal information. Married, we got 2 kids. Youngest is 4. I play a lot of tennis whenever I get a chance to get out. If I'm not in the hospital. I used to scuba dive around the world, but I had to give that up. But still love to travel once COVID restrictions kind of are relaxed.
Love it. Dr. Byun.
Let's see. Well, I was born in New York, raised in Indiana, and traveled, trained in a lot of different places. And I think what drew me to St. Jude's, what I think is it's a hospital that I think everybody is here to do the right thing. I think the services, there's always accountability here. And when things don't go right or they could be better, there's always process of improvement. And I think, even though financially there's always pressure from every place to be financially responsible, that hasn't deterred our patient care. So I don't think that's ever going to happen. I think I don't know if it's because of our mission statement. I don't know if because it's a Catholic organization. I'm not sure, but it just, I think if everybody who comes here, I think everybody will get good care here. I don't think there is anything that happens here that is unexpected or something egregious or anything that's not what expected. So I think, when you come here to St. Jude's, what's going to happen to you is going to be the standard of care and probably beyond.
Nice. What about something personal? You slipped out without that.
Personal. Before I got old, I used to play lots of soccer. I actually played in college a year. I played tennis, and then my I'm becoming so arthritic now, I can't do anything anymore. So I'm just living vicariously through my kids, basically.
Thank you. All right, Dr. Tang.
Yeah, I think I came to St. Jude, I think it's like a little over 2 years ago. I was working down at Mission at one of the other ministries, and the surgeon that was here left. So I originally came to fill a need, but I definitely, I think more than other places I've worked and other places I've trained, noticed that, the administration and the rest of the staff were all very happy to be working there and very supportive of the program. And I think that's just been, really great to kind of grow our program in a supportive environment with good people around you. I think we do a lot of very advanced surgeries, root replacement procedures where we deep branch the whole arch and stent and do all these crazy things. And I think everyone's kind of on board to help and take care of these patients afterwards. I think for me personally, the AFib, the ablation work is what I like the most. My dad has AFib and he's been on Coumadin for like 20, 30 years, and it's pretty terrible for him. But I think being able to do this convergent with the EP guys and being able to I think we've done about 30 of them, and I think 29 of them have gotten out of AFib and been off blood thinners. So I think it's a really great new procedure that can help a lot of people. A lot of people have AFib, and I think being on blood thinners is a huge burden and a huge quality of life problem for a lot of older people, and having that kind of available is can be very helpful, I think.
And how about a little personal something to share with everyone?
I'm grew up in Chicago. I trained on the East Coast, DC, Chesapeake Bay, with the Blue Crabs, and then I came out here for residency and fellowship. Married, and we just had a baby boy who's kind of chubby, 6 months old now. So, doing good.
Congratulations.
Thank you.
Thank you all. Thank you all. I really appreciate you all opening up and sharing, giving us all a little peek into your personal side as well. So now we'll move into our Q&A. And for our guests on the call, please use the Q&A button once again on your bottom navigation bar to type your question. Or if you'd like to ask a question live, please raise your hand using the hand button in the same navigation bar, and the host will unmute you when you are called on to speak. So I'm going to kick it off with one that was sent in by one of our guests in advance of the program. Can your arteries get clogged again if you've already had bypass surgery? Did we stump you? Just kidding.
I guess I could take this one. So in general, there's two kinds of conduits or grafts that we use for bypass. There's the arteries and then the veins. So the arteries tend to last a long time, probably like 15 or 20 years. And then the veins tend to last a little bit less, just because the veins are not used to the high pressure of the arterial system. So those are typically more like 10 to 15 year lifespans, but it really kind of depends on a lot of different factors, whether you are compliant with your medications, whether you make those lifestyle changes. A lot of genetic things go into it. So it's extremely variable for people, but they can eventually develop disease. And then that's when I refer them to Dr. Byun or Dr. Chan to fix that.
Thank you. Okay, we have a question from Ted Jones. Love the team approach mentioned by all. Does that team approach reach down to a specific solution for a single patient? If so, how does that work?
I think that's an important point, right? Because at the end of the day, we talk about community, we talk about populations, but the answer is, what does that happen for you as an individual? So I think there are two different things that we have, and they're complementary. So let's say, for example, the TAVR that Dr. Byun showed. So we have a formal conference on a weekly basis where you have everybody in the room at the same time, where you have the surgeons, you have the imagers, you have the interventional cardiologist, you have our PA and nurse practitioner coordinators saying, hey, let's have all the information on the table. Is this patient best served for surgery, for a valve? Is this sort of an in-between case where we sort of make sure that we give the patients, here are the pros and cons, and make sure you understand that. So that's one way that the team approach comes in. The other approach, which may sound a little old-fashioned, is actually called direct communication. So I'll give an example. When we're talking about the MitraClip patients, I do a transesophageal echo. As soon as I finish, I just call Dr. Rainey. And if he's not, if he can't answer the phone, he goes, hey, we just did a transesophageal echo. Can you look at this? What do you think? I'll call the referring physician, right away and say, hey, what do you think? And a lot of times we have a pretty good idea. Some cases are going to be pretty straightforward surgery, some angiograms. So right away, we're talking amongst each others, trying to figure things out. And we sort of know that if there's going to be a difficult case or there's some difficult decision making, we need to get together and do that as a group. So I think both those formal is very important, those formal weekly meetings, but at the same time, really having a coherent team where you're all trying to be on the same page, have the same understanding. I think what's also important is a team approach. I don't do angiograms at all, but I have an understanding of angiograms. I can sort of have an understanding of the pros and cons, the same as the surgery. The other members of the team, well, they're not imaging all the time, but they do the imaging and they'll challenge me. You think it's X, that's valve leaky. No, quite so much. So I think that open communication and that sort of, if you read the Team of Team books, right, about special forces and how they work or don't work, I think that communication and the fact that everybody has their expertise, but you're respecting the fact that, nobody's know-it-all here and, you got to share the information.
Thank you, Dr. Peled. There's a few questions around the valves. One is, what is the durability of the two valve examples shown? How long are they expected to last? Harriet Boyarsky asks, how long do the clips and the new valves that Dr. Byun discussed last? And what happens if they failed? And then George McDaniel asks, when the stents or other materials are inserted, do they move around? So maybe you can capture all of those in one response, hopefully.
Yeah, I mean, those are all excellent questions. And, all artificial heart valves, that's not mechanical, whether it's, when I mean artificial, that's not mechanical, they're either made out of cow heart material that's made into a heart valve artificially. So it's, people say cow valve or heart valve. There's always a lifespan, whether it's put in surgically or through the groin that I just showed you. Since the one through the groin hasn't been around for very long, like I said, it's been around maybe 8 years. And then the longer studies, we really don't know. But at 5 years out or 6 years, they're doing pretty good. But we don't know at 10 years, they may all fail. But initially it was meant for people who were so old, frail, or too sick to have open heart surgery. Now it's opened up to anybody who wants to have it. And, but I don't think it's a treatment for everybody. For example, if you're below 65, there's a good chance you're going to outlive your heart valve. So if you put a TAVR valve and a worn out heart valve in a 60-year-old, maybe 10 years later, you're going to have another procedure. So we can't take out the old TAVR valve. So what we have to do is, if you want to do another artificial heart valve through the groin, we have to put a new valve inside your old worn out heart valve. At some point, there may not be enough room there, because first you have your old valve there, and then you have the TAVR valve first. If that wears out 10 years, 12 years, you might have to have a third layer of valve. So those are things that we really don't know at this point. But in terms of the durability, they're doing pretty good. I mean, it's neck and neck with the surgical valve in terms of durability, but we don't, our valve longevity, the studies aren't as well known 12, 13 years from now, how they're going to do compared to the surgical valves.
Thank you, Dr. Byun. I have a couple of questions around AFib. Bev Perry asks, if you're AFib, are you automatically a candidate for ablation, or are there certain circumstances that make you a good candidate? And Charles DeLong wants to know, as someone with AFib and as a longtime blood thinner user, how soon will ablation therapy be considered a solid solution?
Well, I think, we are kind of focusing on, because a lot of people have AFib, like a lot of people have AFib. So we focus on the people that do not get good like relief with medication. So the ones we call it, the symptomatic and the refractory, meaning that they keep going back into AFib. So those are the ones we've kind of focused on in the beginning, because those will be people that get the most benefit. But really, anyone with AFib could potentially get treated for it. There's not really any criteria for blood thinners. I think once we do that clip, you can be off the blood thinners, and there's been lots of studies looking at this, that if you put this clip or isolate this part of the heart that forms a lot of the blood clots in atrial fibrillation, then it's just as good as being on blood thinners. So the risks are the same, and that way we can take you off your blood thinners. So there's no like prior conditions to it. I think we are just doing the people that have the most symptoms, and kind of has the biggest impact on their quality of life from the AFib. And we might expand that criteria down the road.
Thank you. What are the pros and cons of a transcatheter valve replacement versus a surgical replacement? And what do you look for when you're deciding on a good candidate for a transcatheter procedure?
I think, that's a great question. And I think I answered part of it, which is when you're young, it's probably a good idea to take the upfront surgical approach, so that as you age, we have more options of doing the TAVR if that surgical valve wears out. If we do the TAVR first in a very young patient, we might putting another layer of valve over and over again may not be the best option if very young, because we're assuming that you're going to be around for another 40 years, 30 years. So you're going to have redo procedures. That's what the most of us will agree with. On the other spectrum, if you're 90 years old, which we have done, I think those are the patients who aren't the strongest surgical candidates. So those are the patients that the less invasive, the better. Somewhere in between 65 to 80, you can go either way. And it's a personal choice. And that's why we discuss it. And so every single time we have to do a TAVR on a patient, a heart surgeon has to meet that person also, because he or she needs to get a full spectrum of opinions to give him the option of why one is better versus the other, so that nobody gets told one perspective that this is the right way, you should choose it this way. So this is like getting a second opinion all the time with every TAVR patient. So that is by law that we have to do that. Whether even if you're 90 years old, there's a good chance you're not going to get the TAVR or the surgical heart valve, but that is part of the process in the United States to get a surgical opinion before we proceed with a TAVR. And I think that one of the question was, do stents move? The answer is no. Once it's placed, it will not move from the artery. And just backing up for the atrial fibrillation, as atrial fibrillation, as I tell all my patients, all of us have our routine of, oh, hi, Mr. Jones, Mrs. Jones, you have AFib, and this is what we do. We all have our introductions and description and education. AFib is a condition that initially starts on and off. And it's a progressive condition that unfortunately has a tendency to become more persistent. So the more on of AFib stays longer. Maybe the first year you go into AFib maybe once every 6 months, once a year. As you age, there's a good chance it's going to occur every 3 months, then every 3 weeks. Instead of lasting for 10 minutes, it's going to start lasting for 10 hours. And AFib is a condition, majority of the time, there are things that are acutely reversible, meaning that if your thyroid is off, you're anemic, or you're sick, you broke a hip, you go into AFib, or you might have pneumonia. A lot of the patients we see are just older people with high blood pressure, diabetes, sleep apnea, who are overweight. Those are the patients who tend to get more AFib. So the best time to do the ablation is when the AFib is still on and off, on and off. If you've been in AFib for 5 years chronically, persistently, that is very hard to get them out of AFib with an ablation. That's when you say AFib ablation is probably not going to work at that point. So people have a certain window when it's most ideal, when they're still going into AFib and then come off again, on and off again. And you know, it's a very frustrating condition because they always say, well, why is it happening now? Oh, it's happening again. So that's why it is a lifelong management.
Thank you. Well, we are about at time, and I want to say there might be a couple of questions we didn't get to, or if you still have any lingering questions, please type them into the chat before you leave the meeting. And Dr. Peled has graciously offered to email responses to any lingering questions you might have. So thank you for that, Dr. Peled. And I want to thank everyone for joining us, and thank you, a big thank you to our speakers for making the time in your busy schedules to engage with our donors and friends. A recording of today's presentation will be made available after the event for those of you who missed parts of it, or if you'd like to share it with family or friends. And we do plan to continue these webcasts for our donors, so please watch your inbox for more information. Now I'm going to do a little commercial. We'd also like you to save the date of September 30th for our Neighbors Helping Neighbors concert on the Hill at Summit House Restaurant. The event will benefit St. Jude's Care for the Poor programs and feature Matt Mauser and the Pete Jacobs Big Band. This is going to be an indoor-outdoor event with both lawn, patio, and indoor seating. So we're switching up our neighbors event. It's going to be a wonderful evening. So please watch for the save the date you see on the screen here. And on behalf of our patients, physicians, and caregivers, thank you all for your continued faithful support of St. Jude and its life-saving, life-changing programs. Take care and stay well.
Thank you.
Thank you.
Bye-bye.